Uh, Hello everyone, greetings once again. After completing the first part of our discussion on the respiratory system of medicine, the final Prof University exam, now we'll be moving to part 2. There's no link between part 1 and part 2 per se, but since the questions were many, I divided it into two parts. This is not from the perspective of NEET, nor is it intended to clear multiple concepts. It is just intended to help you solve multiple MCQs and score marks with respect to it in an objective way. So without further ado, let's start the part 2 of our discussion. The first question is, the most common cause of community acquired pneumonia is? I guess in the previous video as well, I discussed it, that the most common cause of pneumonia overall, be it community acquired, be it hospital acquired, be it nosocomial, be it inpatient, be it outpatient, it has to be pneumococcus. The second is influenza, followed by mycoplasma. So streptococcus pneumoniae is the most common cause. Now, what do they mean by hemolytic streptococcus? Hemolytic streptococcus is basically a streptococcus pyogenes, which will cause your sore throat or strep pharyngitis. It does not have anything to do with community acquired pneumonia, right? So the next question is, which is not a complication of community acquired pneumonia? Is it effusion? Yes. Is it empyema? Yes. Is it endocarditis? Yes. Myocarditis as well? Yes. Can it be hematemesis? No, it has to be hemoptysis. It cannot be hematemesis. So hematemesis is the obvious choice. Basically, blood in sputum or blood which is coming out of the mouth, it can be due to a respiratory cause or a gastrointestinal cause. When it is a gastrointestinal cause, we'll call it hematemesis, which is vomiting blood. Hemoptysis is spitting out blood. So spitting out blood is hemoptysis and vomiting out blood is hematemesis. Which are the other complications of community acquired pneumonia in addition to empyema and endocarditis? It is lung abscess, empyema. Empyema is basically an infected pleural effusion, ARDS, which can progress to sepsis, and DIC. The last three sequelae are very typical for COVID-19 pneumonia. ARDS going into sepsis, disseminated intravascular coagulation, and unfortunately, mortality. The next question is ethambutol causes. Now you need to remember, as I mentioned in the previous video as well, the various drugs which are used in the treatment of tuberculosis. So you have HRZE, and H is isoniazid, R is rifampicin, P is pyrazinamide, and E is basically your ethambutol. So ethambutol is known for causing neuritis, retrobulbar neuritis. So it will cause red-green color blindness. Red urine is basically due to rifampicin. And if some patient asks you that there's red colored urine and the patient is on rifampicin, what would you advise him to do? You would advise him to continue because it does not cause any harm. It is totally harmless. Deafness, ototoxicity, that is because of streptomycin. Peripheral neuritis is because of isoniazid, right? Some similar questions which I thought would be helpful. Red man syndrome is generally caused by vancomycin. Reddish urine discoloration is caused by rifampicin. And reddish discoloration of skin and mucous membranes is caused by clofazimine, and clofazimine happens to be an anti-leprotic drug. Rifampicin and clofazimine are the mainstay of your anti-leprosy drugs, whereas HRZE is basically for your tuberculosis. So remember that red man syndrome is vancomycin, reddish discoloration of urine is rifampicin, and reddish discoloration of skin and mucous membranes is clofazimine. Next question is, hemoptysis is generally characterized by, so when your lungs which are having air is also giving out blood, there is some kind of churning action which is there in the lungs in pulmonary edema. So it will be accompanied by air bubble. So there will be froth as well. So air bubble in sputum is the right answer. It does not have anything to do with abdominal pain. It would have been acute chest pain. Black colored sputum, no. If a person is vomiting black colored sputum or black colored thing, it may be because of hematemesis. Acidic pH of sputum, again, it has no correlation. Pulsus paradoxus is seen in bronchial asthma. Pulsus paradoxus is seen in any condition which will result in an increased right-sided pressure which compresses on your left side as well. So bronchial asthma causes decreased intrathoracic pressure, which will again lead to pulsus paradoxus. Pulsus paradoxus basically means your increase in heart rate when you inspire and decrease in heart rate when you expire. So exaggeration of that normal phenomenon is basically known as pulsus paradoxus. So it is seen in constrictive pericarditis, cardiac tamponade, COPD, and bronchial asthma, right? Obstructive conditions, basically. Obstructive pulmonary conditions, not cardiac conditions. So constrictive pericarditis and cardiac tamponade will not allow your heart to expand. Again, it will cause pressure. Bronchial asthma, COPD, again, it will cause back pressure. So it is pulsus paradoxus. Because your return or your venous inflow increases during inspiration. So in response to that increased preload, there will be increased pumping of the heart or increase in the heart rate, which will be there. FEV1 by FVC ratio is reduced in patients of bronchial asthma. Now, this question is very important because it's a very benign looking question, but it has multiple undertones to it. Your lung diseases, as I mentioned previously, broadly classified into obstructive diseases, restrictive diseases, and vascular diseases. Now, obstructive diseases again classified as COPD, bronchial asthma, bronchiectasis, cystic fibrosis, and bronchiolitis. Your restrictive diseases, extraparenchymal, intraparenchymal. Your intraparenchymal is your interstitial lung disease. Extraparenchymal again, neuromuscular and skeletal. Neuromuscular, you'll have myasthenia gravis. Skeletal, you have ankylosing spondylitis and kyphosis or kyphoscoliosis. And last, you'll have vascular, which is pulmonary hypertension. Now, in obstructive diseases, always remember obstructive diseases are characterized by a decrease in FEV1 by FVC ratio. So decrease FEV1 by FVC ratio, which is an obstructive disease here, it is bronchial asthma. So blindly, the answer would be this. What would happen in lung fibrosis? Lung fibrosis is basically an interstitial lung disease. So in any interstitial lung disease, your vital capacity per se decreases. So when your vital capacity decreases, your FEV1 will also decrease, but the decrease is proportionate. So your FEV1 by FVC is somewhat normal or low normal. But in obstructive diseases, your FEV1 decreases greatly because there is dynamic compression of your airways. Your air cannot escape out from the lung. There is air trapping inside. So your FVC is good, but your FEV1 decreases. The graph, which was like 70% of your expiratory volume should be expired in your first 1 second, but that does not happen. So the graph plateaus a bit. So decreased FEV1 by FVC ratio, bronchial asthma. Normal FEV1 by FVC ratio or decreased, that is seen in lung fibrosis. So this table is again very, very important. FEV1 by FVC ratio decreased, obstructive, which is hyperinflation and air trapping. You did not know the difference between the two. If it is normal or high, basically it is restrictive diseases. Interparenchymal, which is interstitial lung disease, extraparenchymal, neuromuscular and chest wall pathology, and vascular, your FVC itself is normal, right? And for small airway disease, we have a different entity which is known as post expiratory flow rate in the midway, right, between 25 to 75, right, which is characteristic for small airway disease. Farmer's lung is caused by. Now, farmer's lung is basically caused by Thermophilus actinomyces and Aspergillus fumigatus, both of them. So they won't give both of them together. It will be either Aspergillus, it will be either Thermophilus. So if either of the two is there, just mark it. It is also caused by Micropolyspora faeni, and this I had searched it from the net because I didn't find it anywhere. But if someone asks you farmer's lung is caused by, so there are just 3 answers: Aspergillus, Micropolyspora, and Thermoaquaticus, Thermoactinomyces, right? Next is features of empyema include all except. Now, as I mentioned, empyema is basically pleural effusion, which is infected. So again, it would be an exudative type of effusion. So if it is exudative, what would it have? It would have increased pus cells, so it would be purulent. Would it have increased LDH? Yes. Would the fluid glucose be less? Yes. But the fluid pH more than 7? No. It will have an acidic pH because there will be more anaerobic organisms which would be there, and they would promote glycolysis, right? It would consume glucose and it would lead to glycolysis, which will result in a decrease in pH. So your pH would be less than 7. right? Always remember that. Respiratory conditions which are associated with obesity include all except. Now, recently, Bappileri passed away, and he passed away due to obstructive sleep apnea. And that has brought the focus back to respiratory conditions which are associated with morbid obesity. So they include obstructive sleep apnea, Pickwickian syndrome, hypoventilation syndrome. So basically, all of them are included in conditions which are associated with obesity. Now, what is Pickwickian and hypoventilation syndrome? Do let me know in the comment section below. Next question is invasive mechanical ventilation in patients with COPD is indicated in? Is it indicated in severe hypoxemia, respiratory distress, impaired mental status, or all? So the answer is basically all. Any kind of severe respiratory distress which is visible when the patient is not mentally conscious or his mental status is compromised, because that can lead to aspiration pneumonia. Severe hypoxemia, yes. Severe hypoxemia is generally accompanied by increased in carbon dioxide. So all of them are indicators for mechanical ventilation in patients with COPD. Only bactericidal drug which is active against dormant bacilli? Answer is rifampicin. Again, there's no logic here. We just need to know that rifampicin is active against dormant TB bacilli as well. Centriacinar emphysema seen in smokers. Panacinar, alpha-1 antitrypsin deficiency, yes. Childhood respiratory infection, basically that will be seen in congenital forms of emphysema, not in the acquired forms. So emphysema is an enlargement of the air spaces distal to the terminal bronchioles with destruction of their walls. So enlargement of spaces because of airway destruction or their destruction of the wall. Centriacinar, panacinar, paraceptor irregular causes smoking, autoimmune diseases, genetics, air pollution, occupational exposure. Most common symptoms is shortness of breath or dyspnea, persistent cough, sputum or mucus production, chest tightness, tiredness. So all are typical characteristics of obstructive disease. Wheezing is a characteristic of obstructive disease. Chest tightness, again, characteristic of obstructive disease. Next question is following is not commonly seen in ABPA. Now, ABPA stands for allergic bronchopulmonary aspergillosis. So bronchial asthma predisposes, bronchial asthma and cystic fibrosis, both of them predispose to ABPA. But once ABPA sets in, what are the sequelae which is there? You'll have an elevated amount of IgE because it's a anaphylactic thing, allergic bronchopulmonary aspergillosis. You'll have pulmonary bronchiectasis as well, and you'll have pulmonary infiltrates as well. So from the answer which I found to be the best, it was option A, because bronchial asthma and cystic fibrosis predisposes to it. It is not a sequelae, or it does not result from ABPA. So the answer in this case is bronchial asthma. Obstructive pattern on pulmonary function testing is seen in. So berylliosis, asbestosis, silicosis, even bisonosis, all of them are examples of your occupational lung diseases. But bisonosis is basically organic, whereas all the three are inorganic. So this organic thing causes obstructive pattern, whereas berylliosis, asbestosis, silicosis, all of them will cause interstitial or restrictive pattern of lung disease. Again, it is better to know. Now, bovine cough is a feature of. Now, bovine cough terminology per se, it's a misnomer because the cough does not resemble anything which is close to how a bovine coughs. And it is basically related to dysphonia. Dysphonia means your vocal cords are not approximating properly. And it is because of a recurrent laryngeal nerve palsy. And recurrent laryngeal nerve is a branch of vagus. So bovine cough is dysphonia because of recurrent laryngeal nerve palsy. It is not because of tongue paralysis or diaphragmatic palsy or anything. Next question is silent chest in asthmatic patient indicates. It indicates a severe attack. It does not indicate a grave attack which will demand a ventilator. For grave attack demanding a ventilator, you need to have an altered mental status. You need to have severe respiratory distress. Silent chest does not categorize as life-threatening. It is grave, but it is not life-threatening. So remember this distinction. Silent chest is severe, S for S. COPD includes all except. Does it include chronic bronchitis? Yes. Does it include emphysema? Yes. Does it include asthma? No. But the better option here would be pulmonary eosinophilia, because there has been some confusion that do we consider asthma as a part of COPD or do we consider asthma just as a part of obstructive lung disease. Interchangeably, it has been used in both categories. So, but in this case, the answer has to be pulmonary eosinophilia because it is not at all related to COPD. As regards pulmonary eosinophilia, these are the various causes. Eosinophilia is generally seen in any parasitic infection. So parasite has to be a common cause or the most logical cause. Then you'll have Church-Strauss syndrome, and Church-Strauss, I told you, it was eosinophilic granulomatosis with polyangiitis. And what was Wegener's? Wegener's was simply granulomatosis with polyangiitis. So vasculitis, allergic granulomatosis, polyangiitis, eosinophilic granulomatosis with polyangiitis, Sjogren's syndrome, acute and chronic eosinophilic pneumonia, ABPA again, and ILD, which is in the form of cryptogenic organizing pneumonia. Now it is called as BOOP, bronchiolitis obliterans. And you also have Langerhans cell histiocytosis. If you don't remember these, it is fairly enough. It is like manageable. Just remember ABPA, acute and chronic, and in vasculitis, Church-Strauss syndrome, and parasitic infections. All of them can cause basically pulmonary eosinophilia. Gas exchange unit in lungs is acinus. So what is an acinus? I mentioned in the previous video, but I would like if someone would mention it in the comment section below as well. It's a basic respiratory unit. And what is Weibel's airway generation as well? Do let me know. Which is not required in management of acute pulmonary edema? Is O2 required? Yes. Is sublingual nitrates required? Yes. Is morphine required? Yes. Is dopamine required? No, because dopamine, for that you need to have D1 receptors, and those are present on your kidney. So it will cause vasodilation there in the kidneys. It has nothing to do with your pulmonary circulation. Your sublingual nitrates will cause vasodilation because in acute pulmonary edema, as I said, there is vasoconstriction and increased hydrostatic pressure. So though it might look paradoxical, but sublingual nitrates are used. Why is supplemental oxygen used? Supplemental oxygen is used because your respiratory membrane becomes thick. So the diffusion gradient, which was across a thin membrane, has now become thick. So your air exchange is not equally efficient. So that's why you require oxygen. And why morphine? Because morphine will reduce the pain, which is the chest tightness which the person will feel, and it also has some amount of calming effect on the patient. So you'll use morphine as well. You'll not use dopamine. I forgot to mention that questions with these asterisks, these are indicative that the answers given in your Bhalani or unique are incorrect, and these are the correct answers. So just have a look for it. And those questions which has an acute overhead, that means those questions have been repeated multiple number of times. Bulging fissure sign on X-ray is seen in. Is it seen in staph pneumonia? No. Emphysema? No. Pneumococcal pneumonia? No. See, pneumococcal pneumonia will generally cause lobar infiltration or a lobar pneumonia. It will not cause a bulging fissure sign. Emphysema will cause. So now emphysema and chronic bronchitis both are examples of COPD. So you will have increased blackness. Yeah. So you'll have increased blackness on your X-ray and you'll have hyperinflated lungs. And staph pneumonia, what you see typically is a pneumatocele. Pneumatocele is basically a pus-filled cavity. Whereas in Klebsiella pneumonia, you will see a bulging fissure sign. Now, Klebsiella pneumonia is very notorious because not only is it responsible for your inpatient pneumonia, but it has typical characteristics. You will have a bulging fissure sign, and that person will generally come with brownish sputum discoloration. If it was Pseudomonas, it would have been green cough, but brownish is suggestive of Klebsiella pneumonia, and it generally involves the upper lobe. It does not involve the lower lobe, it involves the upper lobe. So upper lobe, brownish sputum, and bulging fissure sign, all are examples or all are characteristics of infection with Klebsiella pneumonia. Right. This is the next question. Complication of lobar pneumonia do not include. Is lung abscess there? Yes, we do have lung abscess. Is suppurative arthritis a part? It can lead to. Infective endocarditis, yes. Amyloidosis, no. Amyloidosis does not have any relation to it. So the complications which I told you were empyema. It was ARDS as well, DIC, ARDS, septicemia, DIC, lung abscess, suppurative arthritis. Now we need to remember that there are two non-suppurative lesions of streptococcal pyogenes, and those are basically your streptococcal glomerular nephritis, PSGN, and it is also your acute. So amyloidosis is not a complication of lobar pneumonia. Silent chest is seen in. Now, purposely, I did not give any options because silent chest is seen in severe asthma. You need to remember that. Finger clubbing is not a usual feature in. So I have told you that it is seen in tumors, seen in bronchiectasis, seen in fibrosing alveolitis. All are true. Tropical eosinophilia, again, it does not have any relation to finger clubbing. Finger clubbing is generally idiopathic. We do not have any particular relation per se, because in any condition in which there is chronic hypoxia, it is postulated that you will have finger clubbing because there is expansion of the subungual matrix of the nail. Tropical eosinophilia, no, it has no relation. So I want you to remember this table, which are the causes of clubbing. You have cyanotic heart disease, cystic fibrosis, lung cancer, mesothelioma. So remember the two cancers, lung cancer and mesothelioma. Lung abscess, bronchiectasis, ulcerative colitis, endocarditis, neurogenic tumors, gastrointestinal tumors. All of them can cause clubbing. So remember with CLUBBING. So this is a clubbed finger, right? Your angle is basically, your lower bond angle is basically increased. So ulcerative colitis, bronchiectasis, cystic fibrosis, mesotheliomas, lung cancers, adenocarcinomas, everything can cause clubbing. FEV1 by FVC is decreased in all except, now you need to eliminate a condition which is not an obstructive disease. Is bronchiectasis obstructive? Yes. Chronic bronchitis? Yes. Emphysema? Yes. Tuberculosis? No. It will cause interstitial disease, right? Drug of choice in Pneumocystis carinii pneumonia. Now this question has been asked multiple times again. It is double dose of trimethoprim sulfamethoxazole, which is also known as cotrimoxazole. So your sulfamethoxazole is basically 400 mg normally, and your trimethoprim generally 80 mg. So 480 is 480 mg. So 480 mg का तुम्हारा tablet रहता है cotrimoxazole का, but you will generally give double dose of it. That means 960 mg of cotrimoxazole is the drug of choice for Pneumocystis carinii pneumonia. Now it is known as Pneumocystis jirovecii. Prophylaxis for acute mountain sickness. The answer is acetazolamide because it is a carbonic anhydrase inhibitor. So always remember, propranolol is an drug of choice for basically essential tremors or flapping tremors, essential tremors basically, and acute thyrotoxicosis. Your drug of choice is propranolol because it will reduce the sympathetic overdrive. Probenecid is a drug which decreases the renal action of renal excretion of many antibiotics, so it prolongs their action. So probenecid is used for that. Diazepam is basically an anxiolytic. Clubbing is seen in mesothelioma, not in silicosis, not in VSD, not in COPD. Is it seen in bronchiectasis, cystic fibrosis? Yes. But COPD per se, that means emphysema and chronic bronchitis? No, clubbing is not seen in that. Pneumocystis carinii infection has the following typical features except, is it perihilar ground glass changes? Yes. Fever with dry cough? Yes. Disproportionate breathlessness with few auscultatory signs? Yes. Is it characterized by pleural effusion? No, it is not characterized by pleural effusion because it is basically a type of atypical pneumonia. So it does not have the progressive sequelae which is seen in classic community acquired pneumonia. Which of the following is a leukotriene receptor antagonist? So leukotriene receptor antagonist. So that is your Montelukast. What is xylutone? Xylutone is basically a drug which is an NSAID, so it will inhibit your LOX enzyme, LOX and COX. So it is your NSAID. Montelukast is leukotriene receptor antagonist. What is fluticasone? Fluticasone is a short-acting steroid. I do not know what indochromil is, so pardon me for that. Yeah, so this, just pause the video or take a screenshot, keep revising this. It is very, very important. Leukotriene antagonist, Montelukast, Safirlukast. Mast cell stabilizers are ketotifen and sodium chromoglycate. Sodium chromoglycate. Basically, it will not lead to the release of histamine by the mast cells. These are leukotriene antagonists. Bronchodilators, basically, you have your sympathomimetics, which are beta-2 agonists, your first line, salbutamol, salmeterol, bambuterol, or formoterol. Methylxanthins, theophylline, basically, and your doxophylline. Anticholinergics are ipratropium and tiotropium bromide. And in corticosteroids, fluticasone, hydrocortisone, prednisolone, right? So hydrocortisone and prednisolone both are systemic. Hydrocortisone is generally given as 100 mg. Just a second. Hydrocortisone is generally given as 100 mg or 50 mg. Prednisolone is generally given as 20 mg or 40 mg. All inhalational include budesonide. Budesonide 50 micrograms puff was used for a very long time in COVID. It was recommended as well. Fluticasone is again used in patients who have inhalational puffs for asthma. And anti-IgE antibody, this is a bonus question. It is omalizumab. MAB is basically monoclonal antibody. So omalizumab is again against anti-IgE. It is better to keep that in mind. All of the following are acquired causes of bronchiectasis except can pneumonia cause? Yes. TB cause? Yes. Inhaled foreign body? Yes. Cystic fibrosis. Now, cystic fibrosis is because of an acquired defect in the CFTR gene, which is cystic fibrosis transmembrane regulator gene. As a result, the secretions are very copious. Your cilia are intact, but the secretions overwhelm your cilia. That's why they are not being cleared. So that can again lead to bronchiectasis. What bronchiectasis is? Ectasia. Ectasia is permanent dilatation. So your dilatation of your bronchi and accumulation of secretions in it, that is basically bronchiectasis. Which are the congenital causes of bronchiectasis? So it is cystic fibrosis, Young syndrome, Carter-Jenner syndrome, William-Campbell syndrome, Munier-Kuhn syndrome. Munier-Kuhn syndrome is basically tracheomegaly and William-Campbell. Remember Campbell and cartilage. So William-Campbell is basically absence of cartilage, and alpha-1 antitrypsin deficiency. Again, it can lead to pan-acinar emphysema, and there can be various emphysematous bullae in the liver as well as in the kidneys. So remember Carter-Jenner and cystic fibrosis. Remember Young's and yellow nail. Alpha-1 antitrypsin, William Campbell, Munier-Kuhn. Why? Because bronchiectasis is again asked as an SAQ. So remembering these would help you recollect and reproduce these same names in your exams. Tubular bronchial breathing is diagnostic of. Now you'll have tubular sound wherever there is increased air or increased bullae. So emphysema is the best answer. Because in consolidation, you will not have tubular bronchial, you will have decreased vesicular sounds. In pleural effusion, there will be muffled sounds. And tubercular cavity, you will have cavernous sounds. Cavity for cavernous sounds. This question was also asked, but I haven't mentioned it later. That's why I mentioned it here in brackets. If there's a cavity, you will have cavernous sounds. Emphysema, bronchitis, tubular sounds. Consolidation, decreased vesicular sounds. Pleural effusion, dull sounds or muffled sounds. Pleural effusion with low glucose content is seen in. Now you need to remember this MCQ. It has been asked multiple number of times. Rheumatoid arthritis, mesothelioma, and a metapneumonic effusion. There are two types of effusion, synpneumonic and metapneumonic. So metapneumonic, rheumatoid arthritis, mesothelioma, all of them have low glucose content. Always remember that. And again, there's an MCQ. What is Kaplan syndrome? Kaplan syndrome is basically rheumatoid arthritis, which is combined with cold workers pneumoconiosis. That is Kaplan syndrome. Nosocomial pneumonia is most common due to, your answer should be gram-negative bacilli. Ideally, now it has turned in favor of streptococcal pneumonia, which is a gram-positive cocci, but still, if given a choice, always go for gram-negative bacilli. Most common type of bronchogenic carcinoma, again, it might seem paradoxical, but there are basically two types of bronchogenic carcinomas. You have small cell carcinoma and non-small cell carcinoma. So in non-small cell carcinoma, you have adenocarcinoma, squamous cell carcinoma, and large cell carcinoma. Small cell carcinoma is generally associated with paraneoplastic syndromes. Forget that. A large cell carcinoma, forget that. Two main carcinomas are adenocarcinoma and squamous cell carcinomas. Adenocarcinomas are generally seen more in females, and they are seen in non-smokers. So you might think that smoking causes lung cancer. So the most common cause of or most common type should be squamous cell, but it has been found that the most common type is adenocarcinoma. That doesn't mean that non-smokers are having lung cancer. So what's the harm in increasing your smoking intake? If it is anyhow not taking it also causes cancer. But there's this concept of odds ratio. The odds of a non-smoker getting cancer is 100 times or 1000 times less than a person who smokes, right? So most common type of bronchogenic carcinoma is adenocarcinoma. Young man develops gross hematuria after an attack of sore throat. What is the likely renal pathology? It has to be acute glomerulonephritis, because it's an example of post-streptococcal glomerulonephritis. Which are the non-suppurative complications of your Streptococcus pyogenes infection? It is acute rheumatic fever, as I mentioned, scarlet fever, streptococcal toxic shock syndrome, acute glomerulonephritis, and pediatric autoimmune diseases. All of them are associated with group A streptococci. Most common X-ray finding in people with HIV and TB. Now, HIV and TB generally, it is seen that they are seen to coexist, because TB and HIV both are immunocompromised states. So if a patient is having TB and if a patient is having HIV and on top of that he develops TB, so which is the pattern which you'll see on X-ray? This is a question which is asked multiple amount of times. Now, if the immunity is good, you will not have secondary changes like cavitation. But if the immunity is so if the immunity is good, you will not have secondary changes like cavitation. So you will generally have bilateral peripheral lower lobe opacities or lower lobe reticular opacities or infiltration. But if your CD4 count is very low, that means the immunity is very less, you will have upper lobe cavitations. So upper lobe infiltrate with cavitation, that is generally the most common X-ray finding in people with HIV. So in people with HIV, you need to assume that the immunity is very poor and the host is immunocompromised. So the best answer would be upper lobe infiltrate with cavitation. If that's not mentioned, then you can go with bilateral lower lobe reticular infiltrates. Aspirin sensitive bronchial asthma is seen in nasal polyps. Again, there's no logic in it. You just need to remember aspirin sensitivity has been associated with nasal polyposis. Crackling crepitations unaltered by coughing are a characteristic of. Now, in any condition where you'll have some amount of pus or some amount of fluid, you'll have crackling crepitations which will be altered by coughing, because when you cough, the act of coughing reduces or shifts the fluid from one part to another part of the lung. So that will lead to a change in the nature of the crepitation. But if there is fibrosis, it is permanent. You cannot change it. So also by coughing, there will be no change in its characteristics. So crackling crepitations which are unaltered by coughing are characteristic of interstitial lung disease, because those are generally characterized by fibrosis. Now, fine crackles are generally seen in conditions where you have acute edema or there is fluid accumulation. So it will be a very fine. It signifies an acute pathophysiology. Whereas coarse crackles means it's like a Velcro. So coarse is like a Velcro. So that is for ILD. Though I've mentioned comment below, but I have told you the answers. And known consequences of asbestosis include all except, does it cause fibrosis? Yes. Pleural effusion? Yes. Mesothelioma? Yes. And which would be the type of pleural effusion? It would be low in glucose, right? So mesothelioma, your rheumatoid arthritis, and what was the other one? Right. So all of them will cause low glucose pulmonary effusion or edema. Pleural effusion or pleural effusion, right? So the known consequences of asbestosis include all of them, but it does not cause small cell carcinoma. It causes mesothelioma, but it does not cause small cell carcinoma. It can progress to squamous cell carcinoma as well, but small cell carcinoma is not an option. Clinical diagnosis of Klebsiella pneumonia is based on all except, as I mentioned, it is upper lobe involvement, bulging fissure sign, chocolate colored sputum or a brown colored sputum. It does not involve the lower lobe. Now, these are just a few tidbits of information which I was a bit lazy to include them in the MCQs which were asked. But there was a question that what is the adverse effect of propranolol on a patient who is an asthmatic? Now, propranolol is a non-specific beta blocker. It will block your beta 1 as well, beta 2 as well. But what will happen when you block beta 2? There will be bronchospasm. So your asthma attack, which is there, it is basically caused by bronchospasm as an eventuality. So if you block beta 2 again, it will exacerbate your asthma. So you don't want that. So propranolol is contraindicated in hypertensives who are asthmatics. Normal FeV even by FVC ratio is generally above 70%. Decreased is obstructive, or normal or high is basically your restrictive diseases. Corticosteroids, they non-specifically reduce your inflammation. Which are the questions which I want you to study for your short answer questions and long answer questions? It's community acquired pneumonia, very, very important. Pleural effusion, very important. Chronic bronchitis versus emphysema, the difference is very important. Bronchiectasis is again an all-time favorite. What should be the flow of your question? The flow of your question should be the etiology. What is the causes? Classification, if it is there, such as in bronchiectasis, there's classification like acquired and congenital forms. And then maybe depending upon the etiology as well, it is there. And management, what should be the respective management? Now, management includes both your diagnostic criteria as well as your treatment. So for example, I'll say pleural effusion. So the diagnostic criteria would be on the basis of Light's criteria and your findings on inspection, palpation, percussion, auscultation. So you need to mention that. And management will be in the form of antibiotics if it is infected, and intercostal drainage if it is causing respiratory distress. So you need to have that flow, and never forget clinical features and management, because that will fetch you the most marks. For classification and etiology, there's not much you can do about it. You'll have to remember it. So with this, we complete the section on respiratory medicine. All the important questions are covered, and out of 30, at least 5 or 6, at least 5 are asked from respiratory medicine, and that means you have secured, or you have confirmed at least 2 to 3 marks, and that will make a huge difference when you step out of the exam hall, when you don't want that dilemma whether would you pass or fail. The typical Shakespearean dilemma: she loves me or she loves me not, will I pass, will I not? So this will give you that confidence to excel in that thing. And again, I'll end with a quote. It says that your authority extends only to the performance of your action. Obtaining or not obtaining the fruit is never within our control. Therefore, do not be the one who performs action with a motive that a specific fruit should be obtained, nor should we insist on not performing an action. So what is in our control is just simply putting efforts, and I'm pretty sure that all of you all will make through. Even we made it through. We never thought we would, but we did, because we had many people who would encourage us and reassure us. So it's time for us to do that. Just keep studying what you are up to. Don't do something new at this point in time, and have faith, have hope. Again, these are tough and trying times, and our prayers are there with the people of Ukraine, because any unopposed aggression has to be condemned in the strongest of terms. So thank you, everyone, and if found helpful, do give it a thumbs up. It's a cliched dialogue, and do let me know as well. Thank you.